Thanks for inviting me. So we've heard a little bit about, we've heard a lot about paediatrics. Sue's kindly talked to us a bit about transition, and hopefully I can conclude today with the other end of the spectrum with adults, and then looking at some possible future directions, sort of picking up on what Stefan had talked about yesterday, but in different conditions. Wrong button. These are my disclosures. So we'll quickly talk through the evidence in adults, and then hopefully you can sort of understand why we have a problem with transition. We'll look at different types of ketogenic diets and which are used in adults, but we spoke about that already, so we'll keep it pretty brief. And then we'll look at how we're going to move forward in adults to try and generate more services. And then a little self-indulgence. My PhD's in glioblastomas and ketogenic diets, so I'll talk a little bit about that. And then I've tried to cover some other areas that are becoming more popular in adults, like weight management and diabetes. It's something I get clinic referrals for but don't see, so we'll go through some of the evidence for those conditions too. So in adults, it all started back in 1930 with the story of paediatrics as well, but with 100 case studies. And then we've progressed through in like the late noughties to the use of classical ketogenic diets in adults, and then we've moved on to the use of modified Atkins diets in adults to try and improve palatability. But it's important to understand that this evidence is based on like observational studies, and it's not based on randomized control trials. So although the evidence looks quite positive and sort of half the patients might experience a 50% seizure reduction, they're quite often like a self-selected population. So it's not powered to look at effectiveness, and it's worth bearing that in mind going forwards. But we have recently had a randomized control trial. It's been the first one that came out of Iran. And they used a modified Atkins diet versus a control for 2 months, but still only with sort of 66 people, so it's probably underpowered to look at effectiveness properly, but it's still a good move in the adult area that we've finally got an RCT. And they found that 35% of the adults in the modified Atkins diet group experienced a 50% seizure reduction, so perhaps not quite as good as the evidence that we've just seen on the observational studies. And then just last year we had our second randomised control trial. Unfortunately, this came out just after we published the Cochrane, so it's not in this time, but it'll be in the amendment. And this one, again, used the modified Atkins diet, but for 3 months. But they really struggled to recruit. So even after 6 years of recruiting patients, they had 75 people enrolled, but closed early. And I think the fact that it's been underpowered might have affected the results. So in this paper we find that the modified Atkins diet and the control diet actually have no difference in seizure reduction, and in the group I've done a risk analysis and talk about it having a moderate benefit, so about a 25% seizure reduction, but it could be because of the way it was powered and they've not adequately recruited to their trial. So how does this sort of prospective evidence and a couple of small RCTs translate to practice? And Sue showed this slide before, but I just wanted to make a couple of other points. That in 2010 in the UK and Ireland, we had 2 adult services. And when we did this study as part of the Ketogenic Research Network, there was 7 adult services across the UK. Predominantly the big ones were in London, Birmingham and Dublin, and then we've got a couple of others dotted around like Liverpool as well. But because of that evidence, and in the UK it needs to be evidence-based practice, so through randomised control trials, that goes into NICE guidance, and it's NICE guidance that then funds our services, but unfortunately ketogenic diets and NICE guidance is for paediatrics and not for adults, and that's based on the lack of sort of large-scale RCTs that we have or don't have at the moment. So from a contraindications point of view, very similar to paediatrics, but hopefully by the time they've gotten to an adult service, we appreciate if they've got a metabolic disorder or not, so the screening could be a little bit different. We also need to consider the chronic conditions like type 2 diabetes that we might be experiencing if we need to liaise with our diabetes team like we heard this morning. And in pregnancy, ketogenic diets can be tetragenic, so we would try and avoid putting someone who's pregnant on a ketogenic diet. And then what other factors do we need to consider? So are our patients coming in expecting to try a ketogenic diet and be seizure-free? Because if that's the case, then it's probably going to be a pretty unlikely outcome. So it's trying to talk to them about what their expectations are, what we think they might be able to achieve from trying a ketogenic diet. Looking at the evidence we've just discussed, it could be a 25% seizure reduction or a 35 or a 50%, but it's probably going to be quite unlikely for them to be completely seizure-free in most cases. And what sort of support do they have? So are they independently able to sort of do all the maths that we expect them to do around the ketogenic diet, or are they in supported living? Are they relying on their relatives or their carers? And that sort of element of it we'll pick up a little later on in a qualitative study. And looking at their dietary preferences, so with children maybe it's a little bit easier. I don't know, because they're going to school, that's still hard to deal with. But if patients are used to eating out, or more particularly if they have really poor cooking skills and they're heavily reliant on ready meals, then we're going to have trouble trying to negotiate our ketogenic diet. And then how will they monitor the diet? Are they able to do blood ketones, or are they better doing urinary ketones? Is that going to be easier for them? And obviously in the UK we have a cost implication associated with everything as well, the urinary ketones being cheaper. So when the evidence came out, we were looking at classical ketogenic diets and then more modified Atkins diets to try and help improve palatability. And I'd say across adult practice in the UK and Ireland at least, the two diets that we predominantly use are modified Atkins diet or a modified ketogenic diet. I just wanted to try and explain what we understand to be a modified ketogenic diet in a little bit more detail. So as part of the Ketogenic Dietitians Research Network, we've done a study trying to understand and unpick what dietitians are doing and what they mean by this modified ketogenic diet, like in which ways are we modifying it and where are we going. So it was accepted just this month, so it's only just been published, which is quite nice for today. So it appears that a modified ketogenic diet sort of coming along the spectrum of ketogenic diets and is probably placed somewhere in the middle from the study that we've done. And the carbohydrate is very similar to a modified Atkins diet, so coming out around 15 to 30 grams a day, or about 5% of total energy requirements. The fat, where it's sort of ad lim in the modified Atkins diet, is actually a little bit more calculated in the modified ketogenic diet, adapting the principles perhaps more of classical. So in some cases it's being weighed, and in some cases it's using household measures like spoons and to try and make it a little bit easier, but it's very much a calculated amount that's provided. Protein's still ad lib. Ketone testing can be urinary or blood, or both, depending on the service and what's available. And something else quite interesting is that we're including MCT and LCT products in a modified ketogenic diet and for the duration of the diet, or as and when they're required by the patient, whereas in a modified Atkins diet they're only usually used at instigation. So it seems to be a bit of a hybrid, but it's quite nice that it's been published, and there's a lot of detail in there about how it's initiated and fine-tuned, and again how it's sort of weaned off if people are interested in a bit more detail. So moving forwards in adults, both the Cochrane review and NICE guidelines suggest that there needs to be a high-powered RCT. And when we say high-powered, we're talking of a sample size of 300 plus. There's a lack of funded services, particularly in the UK, due to the lack of evidence at the moment. And like Sue picked up on, there needs to be more neurologists and more dietitians in the adult services that are interested and trained or have knowledge of ketogenic diets to try and make it happen. So in Liverpool, we've been trying to move forwards with the adult RCT. We've done our feasibility work, which was published last year, and it's in two parts. So we've done a survey initially to try and understand patients' interests, and then we've done a feasibility study in clinic to try and understand if our general epilepsy population, refractory epilepsy population, would follow a ketogenic diet. So 42% of them would be willing to take part in an RCT, which is really important for us when we're doing trial design to try and understand what our recruitment rates are going to be, especially with the other trials struggling to recruit. Of the 17 that we started on diet over the 6-month period, about 50% stayed on for 3 months. We had a few issues with constipation and loose stools, but they generally resolved in the first 2 weeks just through doing dietary changes as you'd expect. But most importantly, we're able to run a cost-effective service. It costs about £250 a patient for the initial 12-week intervention. the intervention on this side, where it's heavily detailed in the protocol's heavily detailed in the publication if you'd like further details, if you're looking at setting up an adult service yourself. So what's next for us is that we're looking at putting an application into the NIHR, which is the research funding body in the UK for a multi-centre RCT. So it'd be about 10 centres across the UK and Ireland. And that's being led by Tony Mawson, who's a consultant neurologist that we work with. So I wanted to spend a little bit of time as well going through other applications of the ketogenic diet, which we picked up on yesterday about there being a lack of evidence. So we're going to explore this lack of evidence, particularly in glioblastoma. So I come from a nutrition support background in neurology, and then moved into keto with epilepsy. And then once I opened a ketogenic epilepsy service, we opened it at the Walton Centre, then it became these patients with glioblastomas were asking if we could help them go on the diet because of what they've read online and things like that. So that's sort of how I ended up getting into glioblastoma. But they're two very different categories of people. So the type of person that we were seeing with chronic epilepsy is quite different to the type of person that we see with a glioblastoma. And it's particularly to do with the poor prognosis. And then there's this whole quality of life versus quantity of life, which is some of the predicaments with starting someone with this sort of condition on a ketogenic diet, and the motivations are very different. So for those who glioblastoma is new to, I've got a little quick fact check. So it's the commonest malignant primary brain tumour. It's still quite rare. It affects 2 to 3 people per 100,000. But despite these patients having a maximum surgical resection, undergoing chemoradiotherapy, the survival is still only about 12 to 14 months. So the prognosis is pretty limited. And patients seem to be seeking these other treatments or alternative treatments due to a lack of perhaps like conventional progress. So since 2005, which was when there was the breakthrough for temozolomide, which is the chemotherapy we use, there was no other breakthroughs until 2017 when the Novo TTF came in, which is Tumour Treating Fields. It essentially involves the patient wearing electrodes, and that stops the cells breaking down. We won't go into it too much, but that's been the most recent breakthrough, despite the fact of the heavy investment in targeted drug trials. So it's unfortunately for these patients, not a lot of treatment options for them. But in sort of other news, taking a little sidestep, £20 million going to be invested in brain tumour research in the next 5 years across the UK, and that's predominantly due to I don't know if in Europe you would know of Tessa Jowell, but she was one of our MPs that unfortunately got glioblastoma. And sort of following off the back of that, they're going to invest more heavily in brain tumour research, which is good news. So the current evidence. So initially it was thought to work through this Warburg effect, so the fact that there's lower blood glucose would be sort of inhibit the tumour from growing because the tumour would survive on sugar. But that's sort of took a bit of a turn now, and I actually think it might be the beta-hydroxybutyrate that's making a difference. And then there's a lot of talk as in epilepsy with the C8-C10s again in brain tumour research too. So I'm going to quickly go through this. So we're looking at the pink and the black lines. So the pink and the black lines are the MCT, the C8 and C10. Then we've got long-chain triglycerides and then a control diet as well. And it's this is in animal models, but the animal models for the ones on MCT8 and 10 have a slower tumour growth and a greater survival. So it's how that translates into people as a different kettle of fish, but in animals is quite promising. And in rodent models, this is from Adrienne Scheck's lab, so anyone who works in keto oncology would know of Adrienne. And she's shown that the top graph is a standard diet and a ketogenic diet, and the survival's prolonged. But what's really interesting is when you give a standard diet in animal models with radiotherapy to try and reflect what we're doing in people, and then you have radiotherapy with a ketogenic diet, 75% of the animals are still alive at the point at which we would usually terminate the animal, which is quite promising to show that it's having some sort of positive effect with the radiotherapy. But we need to cure more than just mice. So just the fact that it works in people, like we said yesterday, animal models doesn't equal dietary advice, so we need to spend a bit more time trying to figure out what's going on and how that translates. And the James Lind Alliance is a priority setting partnership. There's one for all different types of conditions, so like renal and things like this too. But they have highlighted that patients, researchers and clinicians come up with a top 10 priority list for research going forwards. And lifestyle factors, which include diet on tumour growth, is one of their top 10 research priorities. So we're hoping that that will enable us to do a little bit more research in this field. But the evidence in people is really quite limited. So we did a systematic review, and there's 3 case reports, one retrospective study and 2 prospective studies. And they're all using different types of ketogenic diets at different points in this patient pathway. So some of them are doing it pre-surgery, during treatment, or at recurrence, or at palliation. And they're using different types of ketogenic diets, and some of them are using energy-restricted ketogenic diets as well, which inevitably then leads to this 13% weight loss because the patient's only eating 600 calories. So it's sort of deciding which is the best approach. So we have a problem. The fact there's not very much evidence. Our services are all around paediatrics, so we've still got a problem in adults. And it's certainly not mainstream to do ketogenic diets in oncology. So this led us to do the Keating study. This is a study that I've been undertaking for my PhD, and has led us to design a feasibility study. So before you can go on to get funding for a randomized control trial, can you recruit to the trial? If you can recruit, can you retain patients on the diet? Because what's the point if we can't get them to do the diet? And we did this through a prospective, non-blinded, randomised pilot study, just recruiting 12 patients. It's quite a rare condition. And we were randomising them to MCT or MKD. And also wanted to try and understand about the patient's decision-making. So why do these patients want to take part in a ketogenic study? Why do they want to follow a ketogenic diet when they've got a glioblastoma? That's something at the moment that's not known. So we embedded a qualitative study and interviewed patients and their carers. And then moving forwards from the feasibility study, in order to design an RCT, we wanted to know what improvements need to be made. And if anyone's interested in the full protocol, it's been published, so we won't go into it in too much detail. And we're looking at 2 types of ketogenic diets, the modified ketogenic diet, which we've just discussed, and an MCT diet predominantly based on that animal model paper, and some of the case study papers use MCT as well. And initially I was trying to get them up to about 30% MCT, but my adults could only actually tolerate it up to about 25%. So that was a little learning note to take away if anyone's looking at MCT in adults. This is the standard consort diagram, but really important to note for us was we recruited quite well, but then we went on to have problems with retention. So of the 12 people recruited, we randomised them 6 and 6. But of the 12 patients randomised, only 4 completed the 12-week study, 3 of which were in their MCT diet. And our problems with retention generally came around week 6. If we could get them past week 6, then they stay on diet for the longer term, but that seems to be a cut-off point. But important to note is that they have radiochemotherapy for 6 weeks, and it's when they get to the end of the radiochemotherapy that they then stop the diet. And it's the patients with the lower ketones that seem to be the ones that are withdrawing rather than those with the higher ketones. And this is explained in our qualitative study, which I'm going to take you through. So initially, when we were asking patients about why they wanted to take part, there was 2 types of patient. The ones who consented, who made quite an immediate knee-jerk decision, I want to take part in the study, and felt that quantity of life was everything to them. That's why they took part. And then we had our considered decliners, so they were quite deliberate and very sort of considered and rational in the decision that they were making. It took a lot of time to think about it, and actually felt that quality of life was more important for them at this time, and that a ketogenic diet would inhibit their quality of life. Then for the patients who took part, they then went on to seek approval from a relative. If the relative's decision matched theirs, they continued in the study, but quite interestingly, if the relative's decision was controversial to theirs, then they dropped out of the study after randomization, after receiving the education, but before starting the diet. And then for the patients who tried the diet, they then had a positive experience or a negative experience in the study. And by a positive experience, they report that the high ketones were really motivating factors for them. They attributed their clear scans to be due to the fact that they were doing a ketogenic diet rather than the fact that they were having the other treatment. And found sort of good news stories online, and that reiterated that they'd made the right decision for them in taking part in a ketogenic diet. But some of our other patients had quite a negative experience, and they were the patients that had the low ketones. They found the low ketones to be really demoralizing. And that led to an extra burden for them, but then they also began to appreciate that they placed a burden on their relative at a time that was quite stressful for them, but they placed this burden on the relative and the need to not only provide care for them but also make the ketogenic meals. And then talk about how you really need to try the diet to appreciate its harsh reality, and they were the words that they used, which led to them withdrawing at about week 6. And it's these patients that withdrew and those who declined that felt that the 12-week study period was too long and that something shorter would be more attainable for them. So going forwards, although we can recruit to the study, we knew that we needed to make changes. The first one being that 6 weeks on diet is likely to be more feasible, and that would enable us to have better retention, but the 6 weeks would need to be offered alongside perhaps a radiotherapy if that's where it is being shown to be most effective in animal models. But this isn't a study of effectiveness, it's one of feasibility, so we can't sort of make any conclusions about how it improves overall survival. We need to optimise the decision-making and support our patients with their decision-making. So it was actually the patients who withdrew were from areas of lower socioeconomic status than those who sort of stayed in the study or made the initial decision to decline. So for us going forwards, we knew that we needed to support these patients a bit better. And the role of caregivers shouldn't be underestimated. So although these patients come to clinic all the time, and I feel like I know them really well, actually it wasn't until we did the qualitative study didn't have any concept of sort of what impact that was placing on the relative, which was quite an important point. So before we move on, I've put some evidence together for other conditions, but the conditions in adults that I generally get asked a lot of questions about, so I thought we'd flick through quickly a couple of other bits. So weight management's a topic of interest nearly as much as diabetes, but we're not talking just low carb here, it's low carb ketogenic diet, and if anyone wants any further information, there was a lovely meta-analysis published, and they found that a low carb ketogenic diet actually favoured long-term weight loss as opposed to the traditional low-fat methods which we're using at the moment. The whole diabetes low carb debate has been very popular in the UK. I don't know if it's the same in Europe, but it's certainly a topic of interest. This is a study for type 2 diabetes. It's only a pilot study. They've put patients on a modified Atkins diet, so it is a ketogenic diet rather than just low carb, and found that HbA1c reduced by 16%, which is significant and quite interesting, but again, only a pilot study. It needs a randomized control trial. In oncology, so now that I've started keting, then I started getting a lot of referrals from a lot of other conditions, so I've put a lot of effort into research and what's going on. So in animal models, they're only available for colon, gastric and prostate, so that's still at an animal model level. Interest in lung and pancreatic cancer actually made a phase 2 trials, but they've had real issues with compliance and tolerance in their N=2 population. So again, it's not massive research. And there's actually a lot of ongoing trials in other oncology conditions, but they're all at pilot and feasibility stages. There's no RCTs at the moment. This is a study that recently came out in migraine, and it's a prospective randomized trial of 98 obese women versus a control for 1 month, and they found that attack duration and attack frequency reduced whilst the patients were following a ketogenic diet for a month, and then this returned back to the previous levels once they discontinued a ketogenic diet. But this is again just a proof of concept, so it's not something that's being implemented in clinical practice. And in other neurological conditions, like we heard from Stefan yesterday, there's some feasibility work being done in Alzheimer's disease, and Taylor published something quite interesting, but again, they found, like me, this sort of carer burden, which is you would maybe expect more of in a Alzheimer's population. In autism, there's some interesting studies coming out, but they're predominantly case reports. And then there's some questions being asked around traumatic brain injury, Parkinson's, MS, MND, but again, early animal models, and like Stefan said yesterday, it seems to be that everyone's trying everything, but nothing's really getting past animal models and case reports at the moment. And with that, I'd like to thank my investigators of the Keating study, particularly Michael Jenkinson. I'm completely indebted to all of my patients and relatives, especially the ones that spent a couple of hours talking to me about their experiences for the qualitative study. The KDRN, the Ketogenic Dietitians Research Network, and just a little plug, we've done a UK and Ireland understanding of a modified ketogenic diet, but we'd be super interested to see what's going on in Europe with a modified ketogenic diet, so if anyone would like to collaborate with us on some research, that would be lovely. And I appreciate I'm the last lot, so I'm also happy to take questions on Twitter or email if people would like to leave. Thank you very much.